secondary hyperfunction and secondary hypofunction related to the pituitary. So when I say secondary, where's the problem? Pituitary, right? So when we talked about excess with hyperfunction, excess prolactin. So an adenoma secreting prolactin, adenoma secreting growth hormone, problems with that, and then an adenoma secreting excess ACTH, right? So I get that. And then we shifted gears and talked about the deficiency. The deficiency categories are a little bit less, right? So we talked about growth hormone, deficiency specifically in pediatrics, right? I don't care about the adult presentation. But understand what you do with that. How do those kids present? A kid with growth hormone deficiency? They're not growth, right? They don't have growth, so they're going to be short. So we use that. We do a bunch of labs, bone x-rays, maybe an MRI. What is Endo do to treat that after they do their advanced testing?
Give them growth.
Give them what they're missing. To give them some growth hormone. So it's kind of nice with that. If I have, again with the secondary hypofunction, so anterior hypopituitarism, what are my labs going to look like if I have anterior hypopituitarism regarding, say, the thyroid? What's my TSH? So remember, it's the problem. So if I say it's anterior hypopituitarism, the problem is in the pituitary gland. What does TSH do? It's low. So therefore, what does T4T do? Also low. They're also low because they do what? They do what?
They listen to TSH.
Yeah, they do. They're just listening to what TSH does. So the thyroid, the primary organ is just doing what it's doing. It's creating T4, T3, but it's kind of like controlled by the two hormones, the TSH. So again, okay, we'll switch gears. So if it's growth hormone is deficient, what is IGF-1? Is it low or high? Growth hormone, it's low as well, right? So again, both hormones are low, and it's all because that pituitary is low. Sheehan syndrome, we talked about that, just being able to identify that. Same with patients with TBIs, right? They're just not getting better, understanding to recognize and identify that. And then what was the one emergency we talked about? When somebody typically, maybe they have a history of Sheehan syndrome, maybe they had a history of an adenoma, and there was an infarction or a hemorrhage to the adenoma or to the pituitary. What's the scary thing that happens? Pituitary something. Apoplectic. Yes, yeah. So we lost blood by apoplectic. We lost it, and they present sick or not sick. Sick, right? So really sick. You need to be able to identify that, right? It's a sudden headache, right? They're vomiting. We're worried, and because the pituitary gland is failing, and the pituitary gland is failing, all those hormones aren't getting released. What's the first hormone we need to treat and deal with that can cause this person to tank really fast? There's one hormone that we need to get this person, that pituitary apoplexy. One hormone. I heard it. Cortisol. Give glucocorticoids immediately, okay? All right. It'll come back when we do clinical correlations too. All right. So we have a Jennifer Adenomison, who is a 25-year-old G1P1 female. She's complaining of too dark?
No.
Everyone's okay? All right. So irregular postpartum menstrual cycle for the last 2 years. Initial thoughts? This is Endo. Why are we talking about G1 stuff? Let's get a little more information. What is irregular menstrual cycle? Do we know yet? We need to ask a little information. Is it heavy? Is it light? Is it infrequent? All right. So we found out cycle is infrequent. Her last cycle was about 6 months ago, but it was very light. She has nice pelvic pain, dyspareunia. What's that? Pain with sex. No abnormal vaginal discharge or urinary symptoms. So not a UTI or bacterial vaginosis or something like that. She hasn't stopped lactating since her child was born 2 years ago, even though she stopped breastfeeding a year ago. Additional review of symptoms, she admits to fatigue, of course, it's Endo, everyone's tired, irritability, and possible cold intolerance. All right, we got more history. What are we thinking? So potentially, we want to look at that prolactin level, right? We do a physical exam, skin is dry but no rash. We do a breast exam, and sure enough, we have galactorrhea or some white discharge. Otherwise, unremarkable clinical breast exam. And the rest of our exam, including thyroid, heart, lungs, is all good. What do you guys want to do? Good history, physical exam, what's next? Labs. What labs? Prolactin. Now this is a 25-year-old female. What other labs should we do?
Pregnancy test.
Yes, let's make sure she's not pregnant. What other lab do we do, male or female, when prolactin's high? And this is that cross-reactive thyroid, yes, TSH and T4, which we're going to talk about a lot. And then realistically, we want to check the FSH and LH, estrogen. If it was a male, we'd have testosterone, but I don't quiz you on that stuff yet until the second half. So we do your lab. She's not pregnant. The normal electrolyte liver function. Thyroid is normal. Prolactin, we just all say that's very, very high. Yeah. Okay, so what are her problems? Not diagnosis, what are her problems?
Prolactin.
Yeah, so prolactinemia. She's tired, she has irregular cycles, what else? She's galactorrhea, cold intolerance, all of these things. So what do we do next? We have, those are initial labs. Do we need to do any more labs? One more lab. Just check the prolactin one more time because it's finicky, because we just did a clinical breast exam. So I just do another prolactin, and what imaging do we want? What else? MRI where? Brain. Yeah. Okay, so pituitary brain MRI. And this is what we see. Don't worry, you don't have to read it on the test, but there is an adenoma, microadenoma, so it's less than 1 centimeter. So we have a prolactin secreting microadenoma. We have explanation for the excess prolactin and her symptoms, right? It all goes together. How do we treat it? Dopamine agonist. What are those meds called? Good job. You don't need to know the doses, but there you go. Say she doesn't tolerate meds, then what do you do? Surgery. What's the surgery? Sphenoidal resection. Yeah, go through the nose. Yes. All right. Good job. Sorry, I'm yelling. Sorry. Okay. So, Ned Glanderson is a 30-year-old male. He's coming in for impotency for a 1.5 years. Initial thoughts? Get more information, maybe? Okay. So he admits to weight gain, fatigue, weakness, and a loss of libido. He's having intermittent headaches, and he notices a decrease in his vision, both eyes. What are your initial thoughts? Yeah, macroadenoma, something, because it's a mass effect, right? We have these headaches, and then he's having some other issues. Vitals, any thoughts on vitals? Are we okay with those? Blood pressure is high. His BMI is high. We'll talk about that. So he's at class 1 obesity. But no acute distress. Prominent frontal bossing, widened nose. He lens and intact, but you have impaired visual, peripheral vision. Dental malocclusion, what's that mean? He's down the line there. We don't know if he's always been like that, but it's something we noticed. He has enlarged straight-like hands, otherwise normal. So he has hypotension and these facial features. What is that pointing towards? Acromegaly. What's the hormone in excess? So that we know with acromegaly, it's an adenoma. Yeah, it's growth hormone. It's an adenoma. So the secondary hyper function, right? The problem is in the pituitary due to this adenoma spitting out too much growth hormone. Okay, so Ned, what is his problem list? What does he got going on? What did he come in for? Impotency, libido, he's gaining weight, headaches, peripheral vision loss, hypertension potentially, at least has one elevated blood pressure, and then he has these coarse facial features that we know. All right, what do we want to do next?
Test IGF-1.
Let's do some labs, yeah. Okay, what labs? IGF-1. Can we check, glucose is good too, can we check growth hormone when it's in excess? It's not helpful, right, because it's pulsatile, and various things cause growth hormone to what you eat, sleep, stress, cold, all impact growth hormones, and there's no good range for when it's in excess. So instead, we lean on our feedback loop and we do the IGF-1. Okay. High IGF-1. And we just did a random, it's like, I don't know, 10 in the morning. He's ate breakfast, we were random. What should we do next? We need a fasting one, yeah. So let's do another one. And we get a fasting one, and it is elevated as well. We also get a prolactin on this guy, and it is high. Okay. And then remember the oral glucose tolerance test, is that acronym there, but it's the glucose suppression growth hormone test. So if we give someone glucose, growth hormone should be suppressed, and it should be low. And in this case, it's elevated, right? So what do these labs point to? Two things. Acromegaly, right? Because we have excess growth hormone. And then with the IGF-1, and then we tried to suppress growth hormone with this gross syrupy sugar, and it didn't work. It stayed high. And then we also have elevated prolactin. On a test, I will not give you two conditions in one, but people with acromegaly, 15% of them will have high prolactin levels in their blood. So that kind of explains that low libido and impotence and that sort of thing, right? So we're kind of like tying things together. Gosh, it is colder than it was last time. Oh, sorry. Okay, so here's our summary down here. We have what we already talked about. What do we do next? We're good with labs, probably, yeah. What should we do next? MRI, right? Let's go look for this adenoma. Do we think it's going to be small or big?
Big.
Yeah, probably big. It's a male, and sure enough, it's 3 by 4 by 3 centimeters. And it is impinging on all the things. What's our diagnosis? The primary one. Yeah, acromegaly, which is caused by what? Somatotrophic adenoma. And then he also has hyperprolactinemia. We already know it's a macro. Okay, so what do we do for this guy? Surgery, right? Intentional resection. Perfect. We can, I won't do this to you on the test, we can also give him the dopamine agonist for that excess prolactin symptoms, or prolactinemia, because it potentially can just help him while he's waiting for surgery, okay? Once he's stable, so let's say he has the resection and he's feeling good, what do we tell him? What's going to improve after he has surgery? The soft tissue stuff, right? So potentially some of the facial features, carpal tunnel syndrome, hyperhidrosis, all of that can improve. But what stays? The frontal bossy, right? Hypertension, all of that. Sleep apnea often stays. And then remember, we need to screen these guys. That's you, that's us as PCMs. If we ever see this, we're going to do a colonoscopy, sleep study, diabetes screening, all of that. Okay? Make sense? Okay. All right. That was, yeah, now we're just going to do a few more questions, and then we'll start with that already. So, 27, this is the check on learning we'll do after every lesson. So, 27-year-old male who complains of worsening headaches, decreased vision for the past several weeks. On exam, you notice gynecomastia, peripheral bilateral vision loss, and otherwise normal exam. Imaging reveals an enlargement of the pituitary with encroachment to the cellatorx and optic chiasm. Based on your clinical suspicions, which hormone is most likely being secreted in excess? So not what lab, which hormone? So this is a third order question. You should know the diagnosis from the story, and then we want to know what is being secreted in excess. What do you guys think? A, B, C, D, or E? C. A lot of C's, okay? That's just to help you. Good job. Right? And this is why. It's a male, macro symptoms, and gynecomastia, plus other issues. Okay. Why is it cortisol? It doesn't present like Cushing disease, right? Cushing disease is what? The central obesity, the proximal weakness, the bruising, the pleasant face, the buffalo hump. SIADH, definitely not that. ACTH, same, and then obviously growth hormones, the acromegaly presentation. Which one of the following would not be expected to increase prolactin levels? Nipple piercing, nursing, pregnancy, hypothyroidism, or hyperthyroidism. Which would not expected to cause increase in prolactin. Here are some B's. Anybody else? A, B, C, D? C? I hear an E. Okay. I don't do the negative STEM questions on these. Hyperthyroid. Yes. Okay. This is why. So we knew the top three are gimme, right? Like those are, that. But remember, because TRH, the precursor to TSH, can cause excess prolactin, right? So what does that mean? So when you have a patient with high prolactin, we always check the TSH and T4. If their thyroid labs indicate hypothyroidism, what do we treat first? Hypothyroidism, right? We're going to treat the hypothyroidism first. And then we'll follow up labs, monitor the prolactin, and see if that improves, right? Because the problem with someone who's hypothyroid is it's that excess TRH that's causing prolactin, not an actual adenoma. Okay, does that make sense? Okay. Which of the following is the best treatment for a prolactinoma? Somatostatin analog, dopamine agonist, transmittal resection, radiation, or chemotherapy? B, right? Okay, so prolactinoma, prescription, pill, you obviously just need to know which one, and you guys got that. And these are your reasons why, so if for some reason it didn't make sense, somatostatins are for acromegaly, but I didn't really dive into that, so don't fall for it, because I didn't dive into it, okay? Resection is for your growth hormone secreting and ACTH secreting adenomas, that's your first line. Radiation is not the first line for any of these, right? It's the last resort, and then did I talk about chemotherapy? These are typically benign and heavy interventions for therapy. So, Cushing disease is described as which type of alteration in endocrine function? Cushing disease. So remember, where's the problem?
In the head.
Yes, and from there, is it secondary? If it's in the dome, and is it hyper or hypo for Cushing disease? Hyper. Okay, so what letter? Bravo. Very good. Good job. So again, it says Cushing disease is where? In the dome. It's ACTH dependent excess cortisol. It's in the dome. And so where the problem? Secondary. So we got B or E, and is it hyper or hypo function? It's hyper, right? Excess cortisol. Questions on that? Here's the explanation. More explanation. Oh, I guess I had more. Sorry. Okay, a 42-year-old male patient you suspect of having acromegaly. Which of the following lab tests are considered first line?
IGF-1.
Yeah, IGF-1. We talked about this in our very first slide, and it was kind of mixed between growth hormone and a couple said IGF-1. We know now why, right? We already talked about the pulsatile nature. And then the growth hormone lab itself is not helpful when it's in excess. You guys got that? Here's the explanation why. I think the trickiest one that people could pick accidentally would be the growth hormone. And obviously the best for you. Which of the following terms describes an acute hemorrhage with a pre-existing adenoma? A, Sheehan syndrome, B, SAH, traumatic brain injury, encephalitis, or pituitary apoplexy. What do you have it down to? A or E? Yeah. Is this person pregnant? Did they have a hemorrhage and blood loss when they were, did I tell you that? Is it a female? Yeah. No. So, now which one is it? E. And again, these people typically have a history of adenoma or a history of Cushing syndrome that they're missing, okay? Here are your reasons why. If I didn't talk about it, don't take it. Okay, easier said than done anyway. All right, so lesson 4 lesson is we're going to go over 2 days. It is the thing you're going to see the most out of all the conditions I talk about in this block. This is the most common. Regardless of if you see dependents, peds, or active duty members, you will treat people with thyroid disorders, okay? But luckily, it's like the most common feedback loop, and you guys, I don't know, you guys usually do really well on thyroid disease. So let's talk about the hormones involved in this topic. And so from hypothalamus, TRH, we really only need to understand that in regards to prolactin, right? But otherwise, we don't talk about it much in this lecture at all. TSH is released from the anterior pituitary. Anterior pituitary releases it, and it goes through the bloodstream to the thyroid gland and tells the thyroid gland to work, right? Those follicular cells start to produce T4 and T3. T4 is what you're going to measure because it's what the thyroid produces most of, right? So most of circulating in the blood is T4, and then it's converted to T3, and that's that physiologic active form. So it's not usually converted to T3 until it's in the cells, ready to do its work. Okay. And we'll talk more about this when we go into labs. That should all be reviewed. So the function of the thyroid does a lot. So you have all these things from like temperature regulation, metabolic regulation, protein synthesis, all of that. That's great. That's a previous class. When I think of thyroid function, think of it as like a metabolic hormone, right? It impacts a lot of things, our GI tract, our skin, our energy, all of that stuff. And so when I think of someone who has hypothyroidism, so they don't have enough thyroid, that metabolic knob gets turned down. And they are tired, they're slower bowel movements, they're constipated, bradycardia, weight gain, so everything kind of like turns down, dry skin, hair's falling out. And the opposite with hyperthyroidism, when you have excess hormone, we turn that knob up. And then we have tachycardia, maybe even AFib, various cardio issues. We have bulging eyes, hair loss, weight loss, looser stools, more frequent stools, so we're turning that metabolic thing. They're hot when everybody else is cold, okay? That's all I need you to take from this one. You don't have to memorize it, okay? Feedback loop we talked about the very first day. Just understand here that when T4 or T3, when homeostasis is wrong, and we say it's low, we have low T3 and T4, it communicates to the anterior pituitary and the hypothalamus, okay, so it communicates to both. So if T4 and T3 are low, pituitary is going to be like, all right, I'm on it, I'm going to produce more TSH to stimulate the thyroid to produce more hormone, okay? Once homeostasis is reached, we end that feedback, okay? All right, when we are evaluating, before we go into the diseases, it's important to just understand how we evaluate the thyroid. And that's with glands and some imaging, and I'll introduce one procedure, okay? So there's one lab that helps you with all things thyroid, and it helps you diagnose, and it helps you manage and evaluate if your treatment is working, okay? What lab is that? We talked about TSH, T4, T3. Which one do you guys think? TSH, actually. So TSH, remember, and it's the reason is because the pituitary kind of drives the function of the feedback loop. So this is the single most useful lab that you will order when you're working up someone for thyroid. And again, all of this should make sense, right? So if TSH is low in hyperthyroid state, right? You have excess T4 in the blood, pituitary is going to respond by decreasing TSH, okay? And that'll happen in Graves or other conditions, or if somebody's taking too much thyroid hormone, that TSH would be low. TSH is high when you have hypothyroidism, right? When we don't have enough thyroid in the blood, we're going to increase TSH to reach homeostasis. I do not talk about the excess TSH from the pituitary, thyrotropic adenoma. I don't talk about that. So you really, on the right, you really just need to know primary hypothyroidism. Next we have free T4, or serum-free thyroxine. This is a really good lab to add with TSH. So the first two bases I was at, when I ordered TSH, if I wanted T4, I had to order them separately. But some of your bases will have them together in a thyroid panel. So every time I order TSH, free T4 comes with it, okay? But typically I order them together. But honestly, all I really need to catch something abnormal is that TSH first. And it should make sense. This is very common sense. It's going to be low if it's hypothyroidism, high if it's hyperthyroidism or thyrotoxicosis, okay? That one's, we're going to use this if T4 is great if we're worried about hyper or hypo. Is this for you? It was fast. Okay, I can speed up a little. Okay. T3 is very helpful in hyperthyroidism. When you, and there's two types of labs. There's free T3 and total T3. For the test, it'll always just be T3. Okay, I won't dive into why one's better than the other, but it'll just be T3. This T3 is so critical for hyperthyroidism. Okay, when thyroid hormone is in excess, it helps you define what's going on. It is not helpful in hypothyroidism. You will have your patients come and they're going to ask for, I need T3, I need free T3, I need reverse T3, I need all of these labs. It's not helpful. And we just have to explain to them, like, hey, you're worried about hypothyroidism, right? Because you're gaining weight and you're tired. But T3 is going to be normal for a really, really long time, okay? So T3 is not a helpful lab. So if you want to save resources and money, don't order, you just have to explain it. They're going to, off-base people order this all the time. There's no value added. And I checked this, I remember checking this in clinic, and I even checked it at the beginning, I guess 2 semesters ago, and this stands true. We don't need T3 for hypothyroidism, okay? You'll see what I mean. They all ask for all the labs, and you'll see. Right. So in addition to the T4, T3, and TSH, we have thyroid antibody tests. You don't need to memorize all of these individually, but really, because there's a panel in real life. So there's a thyroid panel, and it checks your antibodies. But people with Hashimoto's, most of them will have anti-TPO, versus people with Graves will have the TSH receptor antibodies. Okay, so there's a trend with these. Why would it be helpful to order these? So you have someone with hypothyroidism. When would you order these? You make the diagnosis. Is their TSH is high, their T4 is low.
Treatment?
Yeah, it's a treatment. And like the underlying cause. This is an autoimmune cause of hypothyroidism. Do I need to order these labs every year? No. This is the one that people will ask for this all the time, but you don't need to keep ordering it because it doesn't really change the way you treat it, okay? But very helpful once the diagnosis of hyper or hypo is made, okay? Questions on that? So do we do this first or do we do TSH first? TSH, okay. All right. Did you guys talk about the radioactive iodine uptakes in rats a little bit?
Yes.
Yeah. So essentially, what happens is you're working somebody up maybe for hyperthyroidism, like maybe it's a really weird, large goiter, or a nodule that's concerning and they're in that hyperthyroid state. You could use this scan, and they give the patient iodine 123. This is non-toxic iodine, but they give it to the patient and they wait 6 to 12 hours, and then they do the scan. And essentially, the black mark, so all of this, that's the tracer that the thyroid absorbs, and it mimics kind of the function of the thyroid. So it helps you with function. It can help evaluate masses and things like that. Okay. I don't order this that much, but it is a useful tool. Sorry, 6 to 24 hours. You can do the scan. Again, primarily you're going to use this for people in that hyperthyroid state, or thyrotoxicosis is the term. or maybe for cancer, or other things like that, okay? So high uptake. High uptake means there's excess activity, excess synthesis, and so the scan, it makes sense that the scan would mimic that. So like Graves, we have high hyperthyroidism, excess hormone being made, and so it lights up. Versus the opposite, we're going to talk hopefully about painful subacute thyroiditis today, or if someone's had thyroid gland damage, it's going to be low, right? Because it's mimicking the function of the thyroid gland at that moment. I'll show you pictures, and I will like really hit home this at the end once we finish the thyroiditis cases. So don't stress out now. It's not. It also, like I said, it also looks at nodules. So on one side we have a hot nodule that's dark and picking up lots of activity versus a cold nodule. Just a 50-50 guess. What do you guys think is scarier? I haven't touched it yet. Cold. Yeah, cold. It's not functioning. Okay. Okay, cool. Yeah, so it's not functioning. It's more likely to be malignant. Now, however, there are only 30% of cold nodules are malignant, but that's still enough that we're going to work these up and evaluate them further. But again, another tool that these radiation scans can help with. And here's a breakup. So you have your normal thyroid, and then in Graves, there's excess activity, right? It's working overdrive, and so it makes sense that it's bigger. We'll talk more about why in some thyroiditis cases it's like this. And then there's your cold nodule. Any questions about that? You're going to order ultrasounds way more than the radioactive iodine scans, but you need to know that it's part of the puzzle when you're working up someone for thyroid disease. But ultrasounds are huge. They help you with, so when you palpate the thyroid gland, can you feel like it's nodule very well, right? You know it's there, but it's really hard to feel. Is this abnormal? Is it stuck to anything? Is there microcalcifications? You can't tell that from a physical exam. So we use our ultrasounds, okay? And you don't have to read an ultrasound in this class because you guys don't do that until next semester. But I order thyroid ultrasounds often. Anyone, where's the thyroid, do you guys think? Any guesses? Yes, yes. Here she is. He is, yes. Okay. So look at this patient. What do you observe on her physical exam? Is there her thyroid enlarged?
Yes.
Yeah, like that. Call it like a goiter. Is it symmetrical or asymmetrical? Does it have nodules? We don't know. We'd have to touch it, right? So this looks like an asymmetrical, diffusely enlarged goiter is what I would call it. And we can ultrasound that, and this is what it looks like. So we have the scan. The scan can have bright colors, right? So it's showing excess activity. And then just look at the thyroid gland is much bigger here than it was before. So usually the spaces are smaller, and then it's asymmetrical. And if there were nodules, you could use this ultrasound to diagnose nodules. And this is when you just love your radiologists, because radiologists will tell you usually if it's a benign nodule, when you should follow it up again, which one needs biopsies and all of that stuff. So we appreciate those guys who sit in a dark corner of the hospital every day. And the last workup is their fine needle aspiration biopsy, or FNAB, and this is help. So you have a nodule and you need to figure out what's going on. You're going to order an FNA, and they essentially, that's ultrasound guided, right? Because, well, there's a lot going on, right? I don't want to accidentally mess with the carotid or the other vessels and nerves in the neck. But they put a 25 to 27 gauge needle into the neck when the patient is just sitting there. They do not numb the patient, or I've never seen them get numbed. I guess you could, because it hurts more to numb them than just to do it. And then there's a suction associated with the needle, and it helps get the tissue for the biopsy. Okay. We'll talk about when we order this for nodules moving forward. So that's kind of the essential workup, labs, imaging, all the things that we're going to refer to when I talk about disorders. Okay. So you can lean back on these if you need it. Any questions? So we're going to focus on hypothyroidism, specifically primary hypothyroidism. So where's the problem if I say primary hypothyroidism? Is it thyroid, right? And is it hyperfunction or no? It's not. It's hypo, right? It's not functioning. All right, jump right in. So failure of the thyroid to secrete what it's supposed to do, right? T4 and T3. The most common cause of this in the United States is Hashimoto's thyroiditis, which is an autoimmune disorder we'll talk about in detail. It's essentially it's infiltration of the lymphocytes, causes inflammation and causes destruction of the follicular cells in the thyroid. Okay. Globally, though, iodine deficiency causes this. We in the United States we have iodine salt, so we don't have this issue. But you'll see in a future slide that there's a lot of countries that deal with this. When women are pregnant, we know the anterior pituitary increases, and so we also know that they need more thyroid hormone while they're pregnant. And we'll talk to you about what to do with those patients that are hypothyroidism pregnant. And then obviously you have your secondary. If I say there's a secondary problem that's in the pituitary, but I'm not talking about that, right? It's super rare. If you ever see it, I'd love for you to email me or text me, which odds are you won't. So again, I just care about primary hypothyroidism. We're looking at these systems, or these symptoms, and remember that metabolic knob is turned down. So weight gain, fatigue, lethargy. That could be kind of all the population, kind of like that. Constipation, constipation could be like if you're not eating enough fiber, if you're not exercising, you're not hydrating. So you can see how just like the first few, it's not real obvious, like, right? So it's like it's a lot of issues, and luckily TSH is super cheap and it's affordable, and so you could, if you have a patient with struggling with fatigue, weight gain, you could order TSH. They'll have cold intolerance. How do you ask me if I have cold intolerance? Do you say, do you have cold intolerance? What's a better way to say that?
Turn the heat up in your car when it's warm outside.
Yeah. Are you cold when everyone else is hot? Are you just cold in the junior classroom? If anybody is warm, maybe have hypothyroidism. Right. You can have menstrual cycles. Typically, people with hypothyroidism will be like a heavy cycle, but it could be light too. Joint pains, carpal tunnel syndrome is a big thing that they can have. Okay. So I'm sure if that helps you. And then what do we see on exam? Bradycardia, right? We're turning the knob down. They can have hypertension, typically diastolic if it's there, but more importantly, you're going to see like brittle, thinning hair, brittle nails. The puffy face and eyelids is more in elderly and in a hypothyroid crisis that we'll talk about at the end. That's could be there. What is delayed relaxation of the DTR? So I hit the DTR, goes, but there's like a delay coming back. So it's like a slow roll back down, okay? That's hypothyroidism. These people can have goiters, or they could have no goiters, all right? You can also see like the lateral hair loss, galactorrhea, some cardiac issues too, especially if these patients go untreated. Typically these patients are women, but males can get this too. And if I told you that the most common cause of hypothyroidism in the U.S. is an autoimmune disease, it should probably make sense that a lot of those people also have celiac disease too, they're autoimmune. Okay. Questions on how these people present? Turning that metabolic knob down. I think you can, when we go to the hyper, hopefully you'll be like, oh yeah, I would not confuse hypo and hyper on a test question because they're very different. Labs, you guys know this, right? TSH, what labs do we do? The single best test for hypothyroidism is a TSH. Why is it high in primary hypothyroidism?
Because it's not working.
It's not working. Yes.
T4 is low.
Yes.
Negative.
Perfect. I just had to ask that because it was a little gray at the beginning, but yes, this isn't working, so the pituitary is trying to respond and react to that. The normal range varies, but it's typically 0.4 to 4. Everyone who doesn't have thyroid disease, usually you run less than 3 or around 1 to 2. So when it comes to treatment, that's where I shoot for treatment if they're less than 50 years old. And then obviously free T4 is low. That makes sense. Or low normal. On my test, it will be low. Okay, in real life, it probably will, but on my test, it will. And again, people come in ask, they always think the fatigue and weight gain is from their thyroid. I screen for it if they come in for fatigue, but a lot of times it's what they're doing and not doing day to day that's causing them to be in that situation. This is that and then this is situational awareness. You can have additional abnormal labs, maybe they're hypoglycemic or anemia. Usually once you treat their hypothyroidism, if they have high cholesterol, it gets improved, okay? Do we need to do imaging for these people? Do we need to do an MRI for them? No, right? Because the problem is they're gland. And if I don't feel any nodules or anything abnormal on the thyroid gland, I don't have to do anything to diagnose this, right? It's just lab and signs and symptoms, okay? I'll tell you when you need to do an ultrasound later, but we just need labs. It's nice. Now, if I have a patient who has hypothyroidism for a long time, maybe they don't have access to health care, or they're diagnosed and they're like, I'm sick of taking this med, I'm fine, I'll be fine, I don't need it. So there are complications long-term if people don't get treated, right? So specifically cardiovascular disease. So you as PCMs will treat the vast majority of your hypothyroid patients, but if they have significant cardiovascular disease, you're going to refer them to Endo. And that's just because of the various complications with that. So otherwise, it's you. Obviously, they'll have increased susceptibility to infection, infertility makes sense, right? Because their cycles are off. It can affect men's sperm. Oh yeah, I did back here. So it affects their sperm morphology. So when we think about sperm, we think of like as long as it's swimming forward, we're good. But no, the morphology and the shape of the sperm make a huge difference for fertility. So again, you might catch this in someone who comes in for fertility workup, and oh by the way, they have hypothyroidism. We'll talk about the mixed edema coma crisis at the end, probably tomorrow. So, if someone has they have primary hypothyroidism, their thyroid gland is not functioning, how do we treat it? Give them what they need. Yeah, we're giving what they're needing, right? Levothyroxine. This should not be new to you guys. Farm, covered in farm. But the biggest thing with this is that we have to give it a good 6 to 8 weeks for it to see if it's working. And that's because remember it's a hormone. It's not a neurotransmitter, a neuro. It happens slow. So we have to build up that T4 and T3 in the blood supply, and we check the labs in 6 to 8 weeks. So what I do in clinic, so this is just FYI, if I see you, say I see you, I diagnose you with hypothyroidism today, the 6th? No, the 5th? This is the 5th. So November 5th, so 3 months in February 5th is when I'm going to give you a 90-day supply of levothyroxine. I'm going to give you 50 micrograms of levothyroxine, and I need labs in 2 months. So I'm just going to be like, hey, January 5th, go get labs. And then, but I give them a 90-day supply, so I give them that buffer. So they have all of January to get that lab done. And if their labs are stable, then they can just continue their dose. If it's not, then they need to reevaluate the dose. Okay, so that's what I mean. That's how I do it, so it's less communicating back and forth with patients, and I just put the lab in so it's active and ready for them. Okay? And the goal of the whole point of giving them levothyroxine is to get that, restore that homeostasis, right? That euthyroid state. Yeah.
I was curious, so from a military perspective, if you get diagnosed with hypothyroidism, that's like a daily pill they have to take.
Yeah.
So does that affect deployment schedule as well?
No. No, it doesn't. Not for that one. Yeah. But there's something called the MSD where it changes all the time, but for restrictions, but no, you're good on that one. Really good question. It's because it doesn't have to be refrigerated. It just has to be taken constantly, every single day, the same time each day. We probably talked about this in farm. It's when we're treating someone with a hormone, especially a metabolic hormone, we need to do it at the same time each day. And you can't take it with any other. You can't take it with food. You can't take it with other vitamins, especially like iron and calcium. Will mess up the absorption. Okay, so a lot of patient education with these people. And if they come back and see you and their labs aren't at goal, ask how they're taking it. So a lot of times it's just they're forgetting it, or they're taking it with their coffee that comes with cream and sugar, right? And that interferes with it. So ideally you have them take it 30 to 60 minutes in the morning before they eat or drink anything. Or if that just doesn't work for them, they can take it at night. Some endocrinologists don't like this, others are just happy they take it, but you want to wait like 2 to 4 hours after your dinner if you're going to take it at night. Same time each day. And you have to stress to these patients that typically this is a long-term treatment. And I always say, like, hey, it's not just, people will be like, oh, I don't want to take a pill for my whole life. No, it's not a pill, it's a hormone that your body needs, it's not making enough of it, right? So it's like we're treating a deficiency and not giving you like a true prescription. That seems to work for their buying, because that's really important because of all the complications that could happen if they're untreated. All right, so weight-based dosing, I'm not going to make you calculate this. Usually you'll start around 50 to 70 micrograms. And they, obviously it's going to be different if they're elderly, okay? Because we're going to start slower and we're going to titrate up a lot slower. The big thing on this is I'm saying micrograms, right? A small dose. And so we adjust these. The adjustment for these could be, you could take, here's the dose. So you're on, you could have 75 micrograms a day. Sometimes you'll see people who are on 75 micrograms 4 days a week, 88, 3 days a week. So you're going to see lots of variety of this, but typically you'll start it on 1 pill daily, same time each day. But you have some flexibility with this. Okay? All right, so I had my patient. I started them on levothyroxine today. It's February. They come back, and their TSH is high still. What do I do with the dose? They were on 50 micrograms, and their TSH is high. What do you think, Eddie?
Up it?
Yeah, you up it, right? But as I up it, I'm going to ask, like, hey, are you taking it? Are you actually taking it every day? Are you taking it with your coffee? Are you taking it fasting, right? So you need to make sure that they're taking it right. And they're like, no, I swear, doing exactly what you want. I haven't missed a dose. Then we're going to increase it from 50 to maybe 75, right? Right? Because that TSH is high, indicating that the dose we gave them isn't enough. Now, what if it's the opposite and their TSH is low? It's like 0.4. And I give them 50 micrograms. So what do I do? Decrease it, right? We're going to dump it down to like 25. Okay. Perfect. And then also make sure, are they taking another supplement? Or are they like my friend said that she's on thyroid meds, and ever since she took it, she's lost a bunch of weight. So I'm going to go to the health food store. I'm going to buy some extra things that help convert help me with make more thyroid hormone and lose weight, so you'll learn that. And the other thing at the bottom, I don't know, did Farm talk to you about the generic use of levothyroxine? So typically we don't give Synthroid, we give levothyroxine. But this is that one time, because again, we're dealing with micrograms and we're dealing with a hormone. That if you have a patient that you just can't get that TSH control, Endo may switch up to spray name Synthroid. And I saw that a lot when I was in school and in my Endo rotation. Just something to put in the back of your mind, not first. Pregnancy. So we know that we need patients who are hypothyroid, or any woman, okay, every woman will need more T4 and T3 while they're pregnant. So if you have a patient who's hypothyroid, she's going to need more, and we're going to have to supply that, right? So as soon as they find out they're pregnant, we need to increase the dose by 20 to 30%, and that's to prevent the IQ scores and things like that, or miscarriage and other things. All right. So if you have a patient who's hypothyroid, she's 26 and she's never had a baby, and you're filling her prescription, be like, hey, do some patient education early. Hey, when you get pregnant, or if you ever start trying, I need you to make sure you reach out to us, and so we can increase that dose. Because are they going to see OB at the 5th week? No, they're going to see you. They're going to get your pregnancy test from you, and they're not usually going to see OB until like 8 to 9 weeks. So again, your job as PCF would be to increase that. Okay, not based on labs, but based on the needs of pregnant patients. Very, very, very important. Questions? There are people who will ask for something called T3 or Cytomel in clinic. You don't need to know that for the test. I would say plug that to Endo. I don't usually manage someone unless they're already on T3. But there's people who will ask for it because it's online. Well, I don't think blogs are a thing, TikTok, I guess. Anyway, it's on there, and they'll come with it. And then the other thing is just to plan to see if there's, have you guys heard of armor thyroid? It is basically, it's taken from desiccated pig thyroid, and it was a thing, and people who were on it loved it, and they wanted it, and I would bridge it and send them to Endo, because just don't do it. It's not safe. All the associations say don't do it, but every now and then, I think in other countries they might still have it. You need to try to get them off of it or send them to Endo for them to renew it, okay? The last time I filled it was like before COVID, but it was just a break. All right, so when do we send our hypothyroid patients to endocrinology? Significant cardiovascular disease, they need to go. It doesn't mean we can't still treat them while we're waiting for evaluation. We do that, or you have that patient that you just can't get their TSH under control, you can send them, okay? And then we'll talk about the emergency situations in just a minute, or sorry, tomorrow. Subclinical, so this is what you're going to see in real life. You're going to have a patient with high TSH and normal T4 over and over and over again, and now you have to decide, do I treat this person with levothyroxine or not? Okay, this is a subclinical case, so is it going to be on the test? No, it's not. It's just going to be in phase 2. So I won't spend too much time on it. I wanted to add this slide because this is what you're going to see a lot, and you have to decide who you treat and who you monitor. And then there are stuff people can buy, thyroid-like meds on Amazon or other places, and they do it for like the weight loss or the energy, but is that safe? No, right? Because of the cardiac issues and things like that. Probably less likely now because there's GLP-1s exist, but pre-GLP-1 era, this was a real thing. I have 2 more slides, and then we can do the break, and then we wrap up hypo. You guys with me? Okay. So 2 slides are pediatric. So cretinism is your congenital hypothyroidism, right? You're born with this, and it's just failure of the thyroid gland to develop and do what it's supposed to do. Luckily, in the United States, when babies are born, we do a blood test, and we screen. It's the heel prick test. If you've had kids, remember you wanted to have babies, and they poke their heel, and it's really sad because the perfect little baby is getting poked and prodded. But it's to screen for disorders like this, and so we catch it in the United States right away. All right, and it's because it's part of that newborn screening test. But for those people who maybe are adopted or not born in the United States, where they don't do the newborn screening, they can present like this. Growth issues, cognitive impairment, they'll have the puffy hands and feet and the enlarged tongue. And it's pretty significant. So how do we treat this patient? We caught it on a newborn screen. Yeah, exactly. We're going to give them levothyroxine. We're going to give them what they need. Ideally before they start to have the cognitive impairment and other disabilities. And then this one you will see in the United States, and this is pediatric childhood hypothyroidism caused by autoimmune thyroiditis, or Hashimoto's. So it's infiltration of the lymphocytes that cause destruction of the thyroid gland. And these patients present very differently than these ones, okay? There's this guy, and then there's this guy. Very different. So they're going to come in and they're going to complain like, hey, my daughter just did her school performance. She's struggling at school. Maybe she's delayed with puberty. She has constipation, hair loss, dry skin, peeling nails. Maybe they have a goiter, or they could be totally asymptomatic. But that metabolic hormone valve is turned down. So you do labs, and the labs will be high TSH, low free T4, and you're going to give them levothyroxine. If you catch this early, potentially they'll catch up on their growth velocity or their growth delay. Okay, potentially, but outcomes vary based on when you treat this. Does this one make sense? This one slide, but does it? You also make sense how this isn't this? Yeah, on a test. Yeah, you see this? Sometimes you forget I'm not teasing you. Yeah, because you haven't, it's not you guys. No, I'm teasing the classes before you. No, but they're very different. Okay, that's it for hypo. We'll come back at quarter till and go to hyper. All things. Now we're going to go to hyperthyroidism, and you're going to see, hopefully, when we talk about signs and symptoms, that these patients present very differently than your hypothyroid. Okay? So a little terminology first. Thyrotoxicosis refers to just excess or elevated T4 and T3. Okay, so I use that term a lot. It encompasses Graves' disease. It encompasses some of these thyroiditis. So it's just a hyperthyroid state based on high T4 and T3. Okay, so I added that just for clarity. And then we're going to go through all of these different conditions that can present in a thyrotoxicosis or hyperthyroid state. Before we go to each individual one, let's go signs and symptoms. Sweating, weight loss, they technically have weight gain too, heat intolerance, right? And they're in this room right now and they're like, I don't know what you guys are talking about. It is hot in here, they're sweating. They can have frequent or loose bowel movements, so diarrhea or just they poop a lot. Fatigue, for sure, everyone at Endo has fatigue. Exertional dyspnea, palpitations, restlessness, anxiety. So you see how it's different? So they're on edge, they're irritable. It's faster, right? We're turning that metabolic knob up. Very different than hypo. Resting tremor, they may complain about that, or you're going to see it on physical exam. Their skin is, instead of dry, it's moist and warm. Tachycardia instead of bradycardia. Rapid relaxation of DTRs. That kind of makes sense, right? The muscle contraction is a lot quicker, or brisk DTRs is kind of what they call it, versus the delayed in hypo. These patients can have goiters, and we'll kind of explain why, especially in Graves', why a lot of times they have goiters, which is the enlarged thyroid gland. Exophthalmos, so those are the eye findings, very common in Graves' disease. And then the cardiac stuff, AFib, premature atrial contractions, the cardiac stuff is a big deal. And then any idea what lid lag is? Yeah, and then we'll talk about the skin findings and nail findings in a separate slide, but osteoporosis is a really big deal. So we talked about osteoporosis last time with some of those adenomas, especially if stuff goes untreated, like with the prolactinoma. Untreated prolactinoma can cause osteoporosis. Cushing disease, that excess cortisol increases the risk of osteoporosis, and so does untreated hypothyroidism. All right, any questions on signs, symptoms? Get this, it is not, you get why this patient is not hypo. Yes. Okay. All right, most common cause of hyperthyroidism or the thyrotoxicosis is Graves' disease. You're going to see this in way more women than males, and typically 20 to 40 years old. This is an autoimmune disorder, okay? And so what happens is it causes essentially hyperfunction. So the antibodies, there's an increase in TSH receptors in the thyroid. So with those increase in receptors, there's more activity, and we have a hyperplasia or hypertrophy of the thyroid gland, so that causes that goiter. And we have increased synthesis of T4 and T3. Okay, so increased activity, often enlarged thyroid gland. Okay, and if we get through thyroiditis, I'll draw a picture of why this is different than the other hyperthyroid cases. Okay, any questions on that? Does that make sense? When we say hyperplasia of the thyroid gland, remember that term? The whole gland gets big, right? Atrophy, the whole gland gets small. So the thyrotoxic symptoms, we talked about that in that whole thing. Goiter is that enlarged. Typically it's asymmetric, but it doesn't have to be. They can have a bruit, so if you want to get fancy, so just like step on there and listen for a bruit. And then we're going to go into the eye symptoms. So there's inflammation of the eye muscles due to this lymphocytic infiltration, right? So there's edema, diplopia, they have blurry vision. If it got really severe, you can have blindness. But this is your classic hyperthyroid Graves eye presentation. And we'll tell you how to treat it and some contraindications if you do have it. Definitely more common in your smokers. Oncholysis is where the nail separates from the nail bed. So, but that usually gets better once you start them on treatment. And then I have never seen pretibial myxedema, but it's in the book, and we'll talk about it. It's not super common, I would say like less than 5%, but you get this non-pitting edema in the lower extremities in the tibia, and it's due to more infiltration too. Okay. I'm not one to be like, throw a picture and be like, what is this? That's stern maybe, but for me, I want you to know like the concepts and stuff. So if I'm gonna throw a picture like this, it's gonna be with a vignette to help you get to the diagnosis. Does that make sense? So it's like, this would be like a piece of the puzzle to get to Graves, or the labs that you see in Graves. Does that make sense? And this is, you can see this too, super, super rare. They have significant inflammation in the connective tissue, periosteum and stuff. So smokers get that. Never seen it. Okay, these labs should absolutely make sense, right? So if we have autoimmune attack to the thyroid gland that increases T4 and T3 synthesis, TSH is what? We have high T4 and T3. What does TSH do in the anterior pituitary? It goes down, right? Because it just reads the blood supply and is like, hey, we don't need any more T4 and T3, so I'm going to cut back. But the thyroid gland is doing what it wants to do, and it just keeps synthesizing more T3 and T4. Specifically in Graves, T3 will be more elevated than T4. This is very classifying. T3 is more elevated, and how you remember that is it's an autoimmune disease where the receptors, there's just more and more synthesis. And because T3 and T4 are high, but especially that T3, they're gonna have more signs and symptoms. So they're gonna be a more severe case than some of these other conditions we talked about. Okay, so those very classic hyperthyroid findings in these people. Hard for them to ignore. Okay, and then we talked about the autoimmune panel for thyroid labs, and most of them will have the receptor antibody will be high. But they could have other ones too. Imaging, you have your radioactive iodine scan, we already talked about this, and it makes sense, right? There's more activity in the thyroid gland, I give them that tracer, it's gonna mimic what the thyroid is doing, and so we're gonna have increased uptake. Usually diffusely throughout the gland. You are not, to make the diagnosis of Graves, you are not required to do an RAIU scan, okay? It can help your clinical picture or get to that diagnosis, but it's not required to make the diagnosis. The labs do it and the clinical presentation alone, okay? It just is another thing you can do for the workup while they're waiting for endocrine, okay? Because do we do these scans in our clinic? No, there go inpatient, because it's radiation, iodine, and all that. All right, so ready to go to treatment? Any questions? Pretty straightforward so far. Okay, so we want to pay symptom control, right? Because they have palpitations, they're irritable, anxious, tachycardic, they're sweaty. So we're going to focus on that. We're going to focus on the eye symptoms, right? It's ophthalmos for people, especially our smokers. And then medication, we're going to talk about the anti-thyroid drugs. In the United States, the definitive treatment is radioactive iodine. 131, so we'll talk about that, and then obviously surgery is still on the table. So, beta blockers. Good old propranolol works really well for this, for the tachycardia, for that tremor, that resting tremor, and just that irritability and restlessness. Will propranolol do anything about the excess T4 and T3? Yeah. Okay. But it's a helpful thing to give them that we as PCMs absolutely can prescribe. And then once they get stable, whether maybe they do the ablation, they can usually be tapered off the program. corticosteroids are great for the exophthalmos patients. Just decreases the inflammatory cells and inflammatory response. And so corticosteroids are what we use to treat these. And we're going to use these especially with smokers, prophylactically after ablation, which I think is coming up. I don't know how to say this. IV teprotumumab? I don't know. That's it's a monoclonal antibody. Anybody better? And that one's a fun one, but it's not. It's FYI, but it's a monoclonal antibody that helps with the infiltration too. So that exists as well. And then obviously artificial tears because their eyes are bulging, and eye dryness is a really irritating condition. So we do that too. And tell them what? To stop smoking, right? They needed a reason. This is it, amongst other things. And then antithyroid meds. You guys know this from Dr. Hart. We have 2 of them, and this is what's going to help inhibit the synthesis of T4 and T3. Okay, methimazole works specifically on T4, and it's a little bit safer as far as liver toxicity and dosing. If I'm going to give a person a med and they only have to take it once a day or twice a day, better compliance, right? But if I have a patient who is interested in getting pregnant, then I need to use PTU, okay? And PTU is for those pregnancy, PTU, but you need to watch their liver enzymes, and they have to take it like 3 or 4 times a day, which is a bummer, but worth it, right? And then obviously there's side effects with this, and you guys feel pretty good about antithyroid meds, PTU, when we use them, why we're using them. We'll talk about how we use them in a thyroid storm emergency tomorrow. Cool thing, you can potentially decrease the size of the goiter with levothyroxine and with antithyroid meds. Not on the test, but kind of a bonus. All right, so I already said, this is an FYI. We have these other medications. Did you guys talk about you probably did about iodinated contrast agents, maybe in farm? Okay, well, next slide. All right, so you just need to know the antithyroid meds, analog, corticosteroids, because that's what you're going to be able to prescribe. But again, ablation of the thyroid is the treatment of choice in the United States for people with Graves' disease. And again, instead of the iodine 123, we're going to give iodine 131, and that is to ablate or kill the function of the thyroid gland. Okay. Now, if I have a patient who is a new mom, and I tell you that they can be radioactive for several days, that's something we should probably counsel our patient about, right? Or do they have child care or help? If they don't, this would not be ideal. We want to do meds for them. Or if we have a patient who wants to have another baby or it's their first time, then we're going to do meds for a while and then save the ablation for later. Because anyone, male or female, who gets this radioactive iodine 131, they can have kids for anywhere from 4 to 6 months. Okay, male too, because it impacts on sperm. Right, so. Yes, it will be the treatment of choice, always in the text and all that, but know that we have other options too, and there's limitations to this. Another limitation to this is people with the exophthalmos or eleptosis. And so those people, typically, if we do the ablation, it can make their eye symptoms worse. So they need to be educated on that. That is a contraindication. And if they do undergo it, and maybe they have mild eye symptoms, I'm definitely giving these people prophylactic corticosteroids. Okay. So we know our symptomatic treatments, propanolol, eye treatments, corticosteroids. We know our antithyroid meds, and then we know about ablation. Now, if I ablate the thyroid, what happens after? It's a successful ablation. Yeah, we're going to levothyroxine. We killed the thyroid, ablated the thyroid, and now we need to supplement with what they no longer make, and that is levothyroxine or supranolol. And then, of course, there's surgical option, especially if they have a pretty significant goiter and maybe it's causing dysphagia or some kind of constrictive symptoms. They're a smoker and they're never going to stop, and they're not great with meds. Maybe we'll go to surgery instead of ablation, or as patient preference, right? We can do this, but with any surgery, there's risk. So you can get damage to the lovely recurrent laryngeal nerve. That's like throwback to ENT days that you forgot long ago, which you could have like hoarseness after so. And again, there are times where you do a complete thyroidectomy or a partial, and obviously they would need levothyroxine after. People who have this surgery, it heals really well. We'll talk about it with thyroid cancer, but it heals really well. And most of the people who have thyroidectomy is due to cancer, not Graves. So, complications. These should absolutely make sense. We have cardiac complications with hyperthyroidism too, right? Sinus attack, AFib, heart failure, right? That metabolic knob is turned up for way too long. Heart doesn't like that after a while, right? Hypercalcemia, osteoporosis. And then it can affect the sperm, fertility, libido, all of that stuff for men and women. And then thyroid storm is that emergency scenario of way too much T4 and T3 that we'll talk about later. Any questions on Graves' disease? Leave this in. That helps you. I'm not going to review it now, but it can be like a tool when you're studying if you want to pull it all together. All right, apathetic hyperthyroidism is usually in your older patients, and it's more like a subtle presentation of hyperthyroidism. Again, your older geriatric patients. You have weight loss and fatigue, but they have AFib or heart failure, and you can't quite figure out why. We're going to order a TSH. You're ordering a TSH on all of these people anyway. You're ordering it a lot. But if you have like new AFib, unexplained, or even mood changes, then you're going to look at their thyroid, and that might be the cause. So they would have low TSH and high T4 and T3. But that T3 isn't as high as it is in Graves' disease patients. Okay. All right. Doing okay? We have time to hopefully get through thyroiditis today, and then we'll take a break. Any questions so far? All right. Here we go. Thyroiditis. What is it's in the name? Thyroiditis. What's going on with thyroid? It's inflamed, right? We have inflammation of the thyroid, and we have a bunch of different causes for this, and we'll go through each one, and you'll know which ones I care about a little bit more than the others. So, inflammation and enlargement of the thyroid gland. And what happens with this is, so you have your thyroid gland, the follicular cells, and there's inflammation due to an autoimmune or an infection. And so when it goes to that gland, there's passive release of T4, because what happens, the thyroid's working fine and it has some storage of T4 buildup. But when it gets attacked, it's probably a little aggressive word, but when it gets attacked by the autoimmune or the virus or the bacteria, you have passive release of T4, which causes this variable hyperthyroid state. And there's this transient euthyroid when that storage runs out, but I don't care so much about that. Then we progress to a hypothyroid state. All right, I'm going to give you lots of examples. We'll talk about this. I can draw a picture if there's time. And a lot of times for thyroid, some of these people with thyroiditis, they restore to normal at the end, and some don't, and they stay in that hypothyroid state. So again, thyroid gets attacked by a virus or autoimmune, passive release of T4 causes T4 levels to go up, hyper, and then it's not working because it's getting attacked, right? So then eventually we get to this hypothyroid state. And you can distinguish between thyroiditis and Graves' disease using that radioactive scan, and that's something I'll draw out. I think there should be time. If not today, then tomorrow. So here's the types: autoimmune, and then a few other ones. I'm going to jump right into autoimmune. Okay. Okay, so these have multiple names, so I'm gonna try to just use one name. I only use one name in the test too. Some have like 3 names, which is silly. It's like footboard fitness. Okay. Autoimmune Hashimoto's thyroiditis is something you've heard of. Also known as lymphocytic thyroiditis. Most common cause of thyroiditis in the United States. Also the most common cause of primary hypothyroidism for kids and adults. Impacts women more than men. Really strong family history. Okay, if your mom, your grandma, your aunt had it, you have higher chances of getting it, whether you're male or female. So it's gradual thyroid failure. So again, you have lymphocytic infiltration to the thyroid gland, and this is autoimmune. Okay, and so with the lymphocytic infiltration, those follicular cells that produce T4 and a little bit of T3 start to fail, and there's destruction of that. So the thyroid gland can't keep up anymore, causing that hypothyroid state of high TSH and low T4. Okay? And then we have that antibody panel that we could get on a patient who are working up for hypothyroidism. And your TPO antibody is typically the most common that will be elevated, but it could be one or the other or both. Not on the test. Just need to know you have that panel for it. Additional causes, iodine deficiency, infections, kids who have like history of radiation, and then medications too. Don't memorize either of these lists, but this should make sense if you have an autoimmune disorder like Hashimoto's thyroiditis, that you have an increased odds of another autoimmune disorder, say lupus, type 1 diabetes, things like that. Okay. I had a patient, she was in Russia, or she was in Chernobyl. She was there when that happened. She had that Hashimoto's and rheumatoid arthritis and all of these things. And she was one, it was really hard to get her TSH under control. I felt for her. But yeah, so she is what I think of when I think of like head or neck radiation. I think of my Chernobyl patient. All right, so signs and symptoms are related to the levels of T4. So you have this variable hyperthyroid state. And a lot of times people don't know or don't feel that, right? Especially if it's mild. But they definitely will come in when they transition to that hypothyroid state. Okay. So lymphocyte infiltration, we have all the storage of T4 goes out, we're hyper, and then we transition to hypo, and I don't like it because I'm constipated, I can't lose weight, I'm tired all the time, my hair's falling out, I'm cold all the time, I'm gonna go see my PA. And we do the labs, and it confirms that hypothyroid. Just so you know, you can catch them in that hyperthyroid state too. Exam varies. You could have the diffuse non-tender enlarged thyroid, or it could be normal. Okay, asymmetrical enlargement or symmetric. Labs. You have, if you're in that hyperthyroid state, those labs should make sense, right? T4 might be a little high, TSH might be a little low, but then they ultimately transition into that hypothyroid. They come and see you, their TSH is high, their free T4 is low. And then we talked about the antibodies, how we can use those as a tool to confirm this primary hypothyroidism is in fact Hashimoto's, based on the antibody panel. Or you have this patient who's just a little restless, their heart rate's a little high, you do labs, and sure enough, they have this mild hyperthyroidism. You could do the panel, and that can help you get it to like, maybe I think this is Hashimoto's and not Graves, based on T3 and the panel. Okay, I'll make it very clear on the test. How do we treat someone with Hashimoto's? Well, if they're in that they actually come in for that hyperthyroid state and they're feeling okay, we just monitor them and do some education. But when they're in clinical hypothyroidism, which is when they're going to likely come see you, we're gonna treat them with levothyroxine. We already know this, right? But you need to educate the patient that this is long-term. Only like 11% of patients with Hashimoto's wean off of levothyroxine. So the vast majority stay on it. I had a patient who had celiac and Hashimoto's, and she like cleaned up her diet like extremely, and she's off levothyroxine. But that's it. I mean, it takes dedication. Not eating out, all of that stuff. That's the only time I've ever seen one of the 11%. But again, this is typically lifetime autoimmune destruction of the follicular cells of the thyroid. And some 30% of people can have a shrinkage of their goiter with treatment. Any questions on this? It's kind of tying in that what we see in primary hypothyroidism. The next autoimmune is postpartum thyroiditis. So who is this going to impact? Postpartum females, right? So sorry, males, you're not. If I have a male patient, don't select postpartum thyroiditis, okay? It happens to 7% of women, and again, they have their baby, and they'll have this potentially, or they have a transient hyperthyroid state, often mild, and they might not come in because what are they dealing with right after they have a baby? A baby, right? And they're not sleeping, so they can dismiss like, oh, I'm not sleeping, I'm on edge, I'm anxious because I'm not sleeping. But then you'll have some women who are like, no, I know my body and something's wrong. And so you might catch them in this hyperthyroid state. So if you have a patient in a mild hyperthyroidism after they've had a baby, this is where your brain should go. And then you want to follow them because you're going to educate them that, hey, guess what's coming? This hypothyroid state. Now, most women, most patients will come in that hypothyroid, right? They had their baby, or they were losing weight, and they were go, 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 and then now they're constipated. They can't lose the weight. They're tired. Their hair isn't growing back, right? They're going to come and see you, and you're going to do labs, and it's going to be that TSH will be high, and the free T4 will be low. Okay? Usually, this is self-limiting, so you're going to have this hyperthyroid followed by this hypo, and 80% will be normal after 12 months. So you're going to be like, hey, if you're symptomatic, I'm going to give you a little bit of levothyroxine, low dose, and then odds are a year after postpartum, or when baby's a year old, this should resolve on its own. But the next time you get pregnant, you have this to look forward to. Most people will have this again, with baby number 2, 3, 4, 5. And half of the people who get postpartum thyroiditis will eventually need forever levothyroxine and transition to primary permanent hypothyroidism. Okay. This is all very redundant, right? You can have a goiter or not. We have that hyperthyroid state. At the beginning, that can be a few months, transitioning to that hypo, 4 to 8 months after delivery. Labs correspond to what state they're in, and then treatment. That hyperthyroid, again, we rarely need treatment. Maybe a propranolol, but we just monitor them, and then we can treat them with levothyroxine if they're very symptomatic, okay? And we monitor them because most of the time, they get better, but they need a lot of education because it can come back. Questions on that? Very overlaps with Hashimoto's, only it's a specific population, and it spontaneously resolves for a lot of people. Now we have silent thyroiditis, which is essentially very similar to postpartum. It's but they're not. It has nothing to do with pregnancy. So it could happen to guys, females, and males. But again, it's the same presentation, just not related to postpartum state. And again, you have this transient hyperthyroid, very, very mild, progresses to hypo, and then over time it gets better. And you have the self-limiting resolution. The cause of this could be idiopathic or lithium or other meds. Very similar to the postpartum slide, but just more concise, okay? Hyperthyroid rarely needs treatment, and you give levothyroxine if they're clinically struggling until it gets better on its own. This is not as common. They say it's as common, but I don't know. I guess it's pretty common. I don't have the percentage up, but you just see Hashimoto's so much more. But this is that potential Hashimoto's patient that gets better. All right, that's it for the autoimmune conditions. We're going to switch into a viral cause. Okay, so painful subacute thyroiditis. So these other ones were not, there was no tenderness, right? And the first one where we have a tender thyroid, and it's related to a virus, typically. Be like a URI, bronchitis, COVID-19. And so that virus infiltrates the thyroid gland, and it causes the same kind of presentation. This hyperthyroid followed by hypo and then resolution. Okay, pretty common. Women more than males. 75% of the patients are females, and then it resolves. Most of them resolve on its own. So again, it's like. So again, you have a URI, you get COVID, and this is like a post-viral inflammatory process that affects the thyroid, right? It presents very differently than the other ones. Yay, okay, very differently. So we have a painful enlarged thyroid. It could be bilaterally enlarged or unilaterally. When I have pain here, that pain radiates to my ears, maybe my jaw. I'm uncomfortable, it hurts when I swallow. It's a post-viral inflammation, so maybe I have a low-grade fever, my throat is sore, I'm not feeling super good. This, you see how this presentation is different than that postpartum or this autoimmune? Okay. It varies on how long it lasts, but again, most of these patients do get better, but they will have that symptomatic hypothyroid state, that triphasic state, hyper, maybe a euthyroid that we don't usually catch, and then that hypo to resolution. 95% solved. Labs make sense, right? Transient hyper, the labs will show that. Then hypo, the labs will show that. And then recovery. ESR is going to be elevated in these people, right? Because it's this post-viral inflammatory process. So we're going to, a current doesn't have CRP in it too, but I would order both. But ESR is high. And you can lean on your anti-thyroid antibodies if you want to help distinguish, but those would typically be low or normal. And then we'll talk about why the scan looks low, but essentially, remember, there's a virus that attacks the follicular cells, and it's destroying them, and so the function of the thyroid on the scan is non-existent. Versus Graves, they're having a party, right? More T4, more T4. Okay, so I'll draw a picture of that. Maybe tomorrow. Wait, I have to go 40, right? Okay, maybe. Okay, so we have a virus that causes, how do we treat it? We know it's self-limiting. This treatment should make sense. Let's give them some NSAIDs, some aspirin. If NSAIDs don't work, and they're still like, I am in pain, I don't feel good, then you can throw on some corticosteroids. If there's severe pain. A lot of times when someone comes in with a cold, they've already tried NSAIDs, right? So they're on ibuprofen and it's not getting better. Those people with severe pain, you can go ahead and start with prednisone or add prednisone at that initial visit. Okay. Why am I giving them propanolol or a beta blocker? They're in that hyperthyroid state, right? Their palpitations, tachycardia. Because that passive release of T4 happened and they are feeling it. And then when would I give them levothyroxine? They're symptomatic in that hypothyroid state, right? So it's a lot of like overlap between the ones, so you're just gonna have to differentiate from really the history to which one is which. Treatment varies, but again, most resolve. Any questions on this viral, painful subacute? This is when I get a virus and a sore throat, something like viral, painful. I don't know how you want to associate the subacute, it gets better. I don't know. However you want to associate the name with virus. Do you have any ideas? All right, and then the other one that has to do with an infection is infectious or suppurative thyroiditis. So this is the bacteria. You see the bacteria at the top. Usually strep or staph. can be parasitic or fungal too, but typically it's a bacterial infection. And this is not, you guys should not get this. It's going to be your immunocompromised or your elderly patients. Or I guess anyone who has a thyroid disease too. But this is typically isn't your young, healthy patient. It's your older, immunocompromised. And again, this is bacterial. So bacterial, they're going to look a little bit worse, right? They have a for sure fever. They are in pain. They have a red, tender mass or a thyroid gland, right? It might be fluctuant. So similar to the painful subacute, but worse, right? That bacteria is causing more problems. When we do a CBC, we're going to see leukocytosis. You can see that shift. TSH or T4 may be variable, but it's that ESR and that CBC and just their presentation that's pointing to this infectious thyroiditis. And we want to treat them with IV antibiotics, and likely they're going to be omitted for drainage if they do that. Okay. You do an FNA to confirm if it's strep or staph or something else. This is angry, right? Yeah, this is not good. But the viral subacute is painful subacute is more common than this. But if you see this, you get like, I don't want this in my clinic. They need IV antibiotics. They need to be monitored at the hospital. And then our last one is super rare. I don't plan on testing you guys on this, but just it's another thyroiditis that I guess could be third game on the pants. But it's elderly female, and it's a instead of an autoimmune infiltration, a viral infiltration, or a bacterial, it's fibrous infiltration. And so with that, we get it gets more constrictive and adherent, and so it can be uncomfortable, right? Because they have dysphagia, the enlargement is really bothering them. There's compression symptoms, okay? You would have to biopsy it to confirm, and I don't care about the treatment, but it's listed there because I'm not gonna. This is super rare. So if you have a patient presenting like this, don't call it IgG4 related thyroiditis, right? This is for that grandma, IgG4, that grandma who has a fibrous infiltration of her thyroid glands. Okay. Sorry, I totally didn't say the name. IgG4 related. So I created this table that kind of breaks down, it's really great, what thyroiditis, it's like a recap of all of it. So you have the cause, how they present clinically, what the labs could be or how you can use labs or diagnostic studies, and then how we usually treat them. This is new, hopefully it helps. I'm a table person, hopefully it helps. So I will try real quick, I'm gonna go back to this, to use this smart screen, and if it takes me more than a minute, I'll do it next when we meet tomorrow so you guys get a longer lunch. But let me try drawing this out. Thyroiditis is a little overwhelming. Our TSH receptors are going crazy. Oh gosh, I really wish I could use my hair. So we have more follicular cells. They are having a party. So this is a thyroid party. And what is going on at this thyroid party? What's being released? T4 and T3, because there's so much T4. We have T3 all over the place. And how do I feel? I feel like crap. I am tacky. I am restless. I have, my nails are sticking my nails are coming from my nail bed, my eyes are bulged, I am unhappy. So when you do the radioactive iodine scan, it makes sense that it's showing hyperfunction, right? That scan blows up, okay? We got that. Now, thyroiditis, specifically subacute, no, that would be bad. Okay, so now we have the subacute painful thyroiditis, which is caused by what? A virus or a bacteria?
Virus.
A virus, right? Infectious is your bacteria. Infectious is bad bacteria. So this is a virus, and I get a cold, and then I have this post-viral inflammation. So you have your little virus that comes in, and it isn't causing more synthesis, it's actually causing failure of the follicular gland. But anytime a virus comes into the thyroid gland, it's like, ah! And what does it do when it screams? It releases its stored T4. So this is why when we have the virus come in, we get a little hyperthyroid state. But it's not a party like Graves' disease, so it's not a ton of T3 and T4. It's just a little mild, variable, transient, whatever word you want to use, hyperthyroid state. So my patient who's in tune with her body, or his, but usually her, she might come in this state, and he might have a mild hyperthyroid state. But the virus keeps doing what it's doing, and what do you think happens to the function of this gland? Yeah, it goes down. It is no longer, because of the virus, it is not doing what it's supposed to be doing. So, oh no party. And then guess what happens? This runs out. That passive release is not there anymore. So now it's sad. And they come in, they're tired, they're constipated, their hair, and now we have that potentially clinical hypothyroid state. Okay? So, but luckily with the virus, we have, it'll return to normal function. So this is self-limiting, and function comes back. Does this right here, these X's, this thing, make sense of why the radioactive iodine screen, it only there's less uptake, right? Because the virus took over, or the autoimmunity, the immune response took over, and so it's not functioning anymore. So that's why it looks like that's why, oh, there she is. It looks, thyroiditis looks like this, right? It looks like this because that either the autoimmunity or the viral caused destruction of the follicular cells. And so specifically in the viral subacute thyroiditis, you'll get this instead of this. But also this person will present worse, they'll have higher T3, okay? So you can kind of use the pathophysiology to solidify thyroiditis and then tie it to the scan. Okay, hopefully that helps. Any questions on that?